Glad to be here. Very excited. As I mentioned when I started, my title has to do with cognitive behavioral therapy for psychosis, and that's in my current role. And I thought when I was going to give this presentation for integrated care, I would do something on pain because I thought it might fit more with integrated care kind of concepts. And the hat that I wore before this was a different CBTP, and that was cognitive behavioral therapy for pain control. So in addition to CBT stuff, I got a lot of hypnosis training. And so some of the work that I did was kind of hypnosis combined with CBT things for pain control things. So it's kind of interesting to go back through some of the material and look at it through that lens, and also realizing CBT really is very transdiagnostic. A lot of what I'm going to talk about for pain, I use routinely working with psychosis. So we can talk about those bridges later as we talk about that. So CBT is a transdiagnostic paradigm. For those of you, I'm guessing many have a little bit of familiarity with CBT. Anyway, this is kind of the model that a lot of people know about, and that is a situation, whatever it is, it's not the situation, it's how we interpret it, how we perceive it, how we make sense of it, that really drives our emotion and behavior, all right? And that can apply to any situation. And so just as a little example, we'll just have you respond to this situation. Maybe just pay attention. What are some initial thoughts that come to your mind and any emotions that go with it? Anybody here want to share? Probably be easier than unmiking folks. Anything come to mind?
Comfort.
Comfort. We won't make Doug pick up the mic because we're concerned about terms. So
Support.
Support kind of comes to mind. There's probably some warmer feelings perhaps related to it, could be part of that. There's a lot of things that could be involved with that. And so this just kind of leads us to the cognitive model, how we might use it. Whenever you see a situation, image of two hands, it leads to certain thoughts, and you might have an emotion or a body sensation, and maybe a behavior. You know, maybe the comforting thoughts, or maybe seeing the hand may lead you to do something. So when I was preparing this, I was thinking, oh, this is a good one for pain. So I would see it and like, oh, someone might need some help and I'm inclined to move. And then as I was working on it over the last couple days, I thought, oh, that's like a couple. And I thought, I didn't get anything for Valentine's Day, so I need to go to the store and get something for my wife, which had a different emotion, and then my behavior went to the floral shop. So, you know, depending upon, there's a lot of things that can affect, you know, what you see and how you respond, all right? So this is one part of it, how we can understand any situation just by paying attention to those automatic thoughts, what we feel and how we respond. Now, underneath that, the cognitive model has some layers to this. It's kind of the onion model, if you will. We were just talking about the immediate spontaneous stuff that you guys just reported. Underneath that, starting with core beliefs and schema, that's kind of the core of it. So core beliefs are developed early in life and formed by family and culture. So these are the things, they're kind of globalized, they're very rigid, they're kind of overgeneralized things. You know, the world is safe, I'm worthwhile, people care about me, some of these core things. And schema are sort of cognitive maps to do things. I have a brushing my teeth, for tying my shoes, a schema for asking a parent for a favor, or if I make a mistake, how do I say that? I develop schemas for that, all right? Now, from that learning, we develop assumptions, attitudes, and rules, all right? So these are intermediate thoughts that guide our behavior, meet our needs, avoid harm, and cope with those underlying beliefs as well, right? So if I need something, do I go to mom or do I go to dad? You know, who do I ask? If I make a mistake, is it okay to tell somebody I made a mistake or not? All right, so if my core belief, I really learned that I really can't do things and I get punished, I may develop some rules around, like, don't let people know I've made mistakes. If I make a mistake, this is bad, all right? Avoid, so then an attitude and a rule could be avoid challenges, all right? And so then an automatic thought could be, hey, will you do this task? Oh no, I don't want to do this. I'm going to get, you know, this is going to be a problem, all right? So there's layers of thinking that leads to these automatic thoughts that affect those thoughts, feelings, and behavior. So just to kind of give you some of that perspective. Simplistic, life through the lens of core beliefs. So if you're going to meet somebody and thinking about asking them for coffee, if you have this, I'm not worthy, who's going to like me, then you're likely to go to thoughts like, why would they want to go with me? I'm not likely to behave in a way, I'm not going to ask them out. If I feel some sense of worth, and why not, then I might have a thought like, this might be fun, let's go ahead and try it. All right, so very simplistic, but just kind of a basic understanding of CBT. The therapist aid things that are in here, it's a site where you can get free resources. There's a nice little video on what is CBT, and lots of free kind of handout stuff too, just as a little thing for that. The other thing that CBT is kind of known for is thinking about things in terms of cycles. All right, and I call it vicious cycles up here. So depression is associated with kind of this downward spiral where you have negative thoughts, beliefs, and assumptions. I can't do things. I'm not effective. I have negative thoughts. Nobody's going to go out with me. Nobody likes me. So my mood is depressed. And then when I meet people, my recall is biased. Like, oh, they kind of looked at me funny. They probably don't want to talk to me, leading to further support those negative thoughts, negative beliefs, and there's kind of this spiral that happens. And Beck and others in the CBT world became somewhat famous for talking about the cognitive triad of depression, all right? And this is, in their thinking, certain disorders come with very specific kinds of thoughts. So with depression, you are likely to see this cognitive triad, negative thoughts about self, about the world or others, and about your future, all right? And so that in their language, they call it the cognitive specificity hypothesis, and that's that certain thoughts kind of go with certain kind of conditions. Anxiety has its own sort of pattern, you know, again, so if something is, I have to go give a speech, as I get closer to it, I feel anxious, and I skip the speech or I don't go, and then the anxiety goes down, all right? But what happens is the next time I go to have to give a speech, then I feel more anxious, all right? And that's kind of the anxiety cycle. And with anxiety and concerns around fear, the thought patterns typically, avoidance is involved, but the pattern of thoughts is overestimation of threat and underestimation of ability to cope. All right, so whenever there's an anxiety problem, breaking it down, it kind of comes to some of those sort of elements are typically involved in some sort of fashion where fear is involved like that. All right, so what does a CBT therapist do? They take these theories, they combine it with the client's experience, and they come up with what's called a formulation. And it's really just getting to know a person's life and really understanding what shaped their core beliefs. Are we identifying any kind of patterns you know, around thoughts, emotions, behavior? Very common one in depression is to stop doing things and then they're in their house and they're not getting any pleasure or any positive things in their life, all right? So that's a pattern that's reinforcing where the energy stays low. And then based on identifying those patterns and understanding the person's background, we develop a plan. And usually with CBT, the goals are about reducing distress in some fashion or improving quality of life in some fashion, all right? So those are the basic areas. So let's apply this to pain. Just a teeny bit about pain, and it's been a while since I've really done a lot of pain work. So just some basic highlights. Pain is very common. 100 million US adults suffer from chronic pain, and this is from the EAD study, 2014, and probably even higher actually. One of the things that's influential from a psychosocial standpoint is gate control theory, which is kind of in the 60s, Melzack and Wall, really kind of introduced the idea of the importance of cognitive, affective, and sensory influences on pain. So it's just not the spinal thalamic pathway, the sensory pathway, here's the signal and you have pain. There's a lot of other factors can influence pain perception and pain behavior. Such things as social and environmental variables like family's response to pain are also associated with pain behaviors and disability levels. And that CBT and other approaches are well suited to address some of the distress here. All right, so how does pain become suffering? This is just going to sort of echo the other spiral that I talked about before. So you have sensory pain, which can be associated with anxiety, low mood, anger, maybe some fatigue. And, when that happens, when the low mood and anxiety is there, we tend to notice more negative things, interpret things a bit more negatively, remember things a little bit more negatively. Think about a day when you start off with a rough day and it's really rough. And then it turns out to be one of those days where it seems like lots of things kind of go wrong in the same day. From the cognitive model, there's a little piece of you're tuned into after your mood and stuff is tilted a certain way to notice the negative stuff a little bit more, all right? And to remember memories of things that were a little bit negative and interpret things maybe a little bit more sensitively. That's kind of how it all together. And so then that could feed, if pain is the issue, negative thoughts, and the term they use in some of the literature is pain catastrophizing, which would then contribute to kind of a more intense or more distress related to pain. And it is indeed correlated with greater physical and psychosocial dysfunction. And so what is pain catastrophizing? Magnification of the threat of pain, oh my gosh, this is going to be terrible. And again, not to minimize that pain is a signal that tells us to be careful, right, to not do certain things, but it gets magnified to the extent that it really slows us down. Ruminating about the pain, so thinking about it over and over and over, and then the perceived inability to cope with the pain. I just can't do anything about this anymore, all right, sort of in those global all or nothing kind of senses. Fear avoidance is another factor, again, limiting functioning, activity avoidance due to pain. And then you very often will see depression, anxiety, and sleep disorders when you've got pain issues that are involved. This is a common pain cycle. It's not the only one, although when I've used this with pain patients, they very often kind of go, oh my gosh, wow, this really applies. So there's pain with inactivity, Often that can be tied with, being out of work. So there's financial worries. So you're not sleeping well. You're also more isolated. So then depression and anxiety kicks in, and then you've got more pain. And then it just kind of circles around like that. All right. The other reason we like cycles is that we can address, from a therapy standpoint, we can kind of address different points in the cycle to try to break the cycle a little bit. Just a teeny bit about efficacy for pain compared to treatment as usual. And this is from a Cochrane review and a bit dated. And this is mostly from that American Psychologist article that's in the reference list in this slide deck that you guys will get. CBT has small effects on pain and disability. So effect sizes are relatively small, moderate effect on the mood and catastrophizing piece of it, because that's kind of what we're targeting. And at 6 to 12 month follow-up, mood was the only significant effect compared to treatment as usual. Compared to other active treatment controls, CBT is not superior necessarily for pain or mood outcomes, and has a small beneficial effect for the catastrophizing part of it and the disability part, both post-treatment and at follow-up. So that's maybe where the key is. All right. So other things can help you deal with the pain, distress, and other things. The CBT part hopefully will help you kind of get back to your life a little bit more. And then there's and I'm not going to go into a lot of detail. They kind of break it down in this study, effects for back pain, which is probably the most common, or at least where there's more studies, has positive effects there for headaches, for orofacial pain, arthritis, not as many studies with arthritis and fibromyalgia pain, limited active control type studies. And then TBI, with the combat, with all of the issues of combat stress and other things coming around, they're starting to do a little bit more work in that area. It's kind of categorized more in the headache sort of area, but there's no RCTs in that as yet. So what is the treatment? It's like any psychotherapy. So the relationship is the first and foremost, and you try to identify goals with the person that you can work towards together. A lot of education and normalizing around what the experience of pain is, what their condition is, trying to understand that. And then it moves to identifying factors that maintain or perpetuate really pain perception and behavior and disability. What are the negative thinking? Images, what avoidance is going on, or overdoing it that's going on, that's contributing to the pain cycle that's happening, and then working with some strategies for those negative thoughts, and enhancing the coping strategies, reducing avoidance behaviors, et cetera, et cetera. All right. If you're going to assess pain beliefs, just some examples if you wanted to look at this, or if this is something that might apply to your practice. I used the McGill Pain Questionnaire in the past. And it's really short, 15 items, my pain felt like, and it kind of gives you different descriptors: throbbing, shooting, burning. And then the other one is inventory of negative thoughts in response to pain. And so that can give you clues to where you might need to work, like I can't do anything anymore. So effectiveness, I'm going to become an invalid. So thinking about their future, there's no hope for me, or no one cares about me, or I'm a burden on the family, or, there's a lot of ways that you can kind of approach this. All right? So the other piece that I use the McGill Pain Questionnaire for is the imagery piece. And the imagery can have some impact on how a person experiences it. So if you kind of pay attention to your foot right now, and imagine that your foot was in a little bit of discomfort, and the discomfort for you looked like that. Sort of pay attention. Do you notice anything just in your physiology? If you think about nails jabbing into your foot, or electric shocks hitting your feet right now, all right, that's your interpretation of pain. All right. And by the expressions, you can see people are like, oh, okay. And this is what happens. I've had people in pain saying, yeah, it's like a shark biting me, or somebody strangling me. So these images, not only they convey the pain, but they add another dimension to it, right? Because that links to other pathways, like a shark biting you. Oh my gosh, there's all that intensity, or I'm standing on nails. And so those things. And then what happens is when you need to move, you anticipate that image, and then you have that fear of all of this coming together. And so some of the work that I would do with hypnosis is, can I change the imagery a little bit? So when you put your feet in hot water, there's some tingling and it hurts a little bit, but it's a different image that has a different soothing mechanism that's tied to it. And so helping people to pay attention to what their automatic piece is, and helping them alter their imagery somewhat, and really practice a different way of imaging the pain experience that's less threatening and has other kind of connections to it. I found helpful in the hypnosis work that I did working with folks. From a CBT standpoint, I'm not going to go into this, but one of our standard helping people identify their negative thoughts, we call it the 3 C's: catch it, check it, and change it. What's the thought that I'm having? What did I tell myself? And I've had back injuries before, and I know that I would, say, oh, if I move, it's going to hurt. Maybe I not to move, because it's just going to keep hurting. And if I really check the evidence and say it does hurt initially, but when I get moving, it's really kind of okay, and I'm a little tired, and my PT person says, if I keep doing this over time, it'll be better. And then if I believe that, which I did, then I kind of am able to move forward and do it. So then I can change my thoughts. It'll be a little uncomfortable, but I can do this. All right. So kind of working it in that way. Additional strategies, relaxation is a very common one. And there's all kinds of strategies we can teach there. Imagery, as I mentioned. Behavior activation, again, if they're not doing anything, then trying to figure out a schedule for folks to do things. And pacing is part of this too. One thing with working with pain, folks would say, I had a great day, so I did 10 things I wanted to do. And then what happens is, well, what happened? Well, then I was down for another week because I overdid it. And so really consciously planning how you want to do that. Working on sleep hygiene, whatever the condition is, if you can improve sleep, it's a good thing. All right? So sleep hygiene and things to help with sleep is great. And then bringing in, problem solving specific to pain issues, like how do I get from here to there, and strategically thinking it through, and bringing in family members. How can family be supportive and not, send additional messages of criticism or whatever, and encourage folks to be able to do things. So bringing family in are really important. So my summary, so chronic and acute pain are quite common, and all of us can relate to that at some level. We've all been hurt in some fashion. Psychological approaches such as CBT have shown to provide benefits for coping with pain. Overall pain is inadequately treated in a variety of settings, and so psychosocial interventions are particularly underutilized and can be very helpful. And there are a number of self-help resources, including technology and web-based trainings are available. And I have in the reference list that you'll get a couple workbooks that seem pretty user-friendly, so that if you want to kind of look at this a little bit and potentially use it. The other thing I want to mention with pain, and I don't know why it reminded me of this, but I work with folks who, with pain conditions, I was working with them around pain, very functional, lives are good. And what sometimes happens is the trauma reemerges from early in life kind of thing. So a couple of people I've worked with were doing quite well, good relationships, working. And when pain happened, in addition to all the discomfort, reactivated kind of traumatic memories that they had sort of dealt with. Life was good enough in other ways, and it didn't come to the surface. So sometimes another thing that will happen is it will remind them, like, oh yeah, they're in pain. Why am I suffering? Will activate other things. Why do I deserve this suffering? And so that some of the pain work may involve some of the core beliefs and intermediate stuff that may not have been to the surface before. Pain may open the pathway to that. So you got to keep your eyes open for that as well. So that's all I have for pain.